For those who are on the web or who I don't know, I have the privilege of serving as Dean of School of Public Health at Boston University, and on behalf of the school, welcome to today's event. So the WHO estimates that in 2001, chronic diseases were approximately 46% of the global burden of disease, and that proportion is expected to rise to 57% by next year. The roots of this rise, as I think many people in the room know, are global in scope: culture, population aging, the socioeconomic drivers of health. These forces transcend borders, and improving health means imagining a truly global approach to these challenges. Today's speaker is one of the leading thinkers in global approaches to these challenges. Onyebuchi Arah is a professor at the Fielding School of Public Health Department of Epidemiology and a professor at the UCLA Department of Statistics. He does a lot of work, but a lot of his work is around epidemiologic methodology, global social epidemiology, and related areas. He has received numerous research, teaching, and service awards, including the Council of Science Editors Award for outstanding contributions to global health policy and practice, and I very much look forward to learning from him this afternoon. Before I turn over the stage to Onye, I just want to acknowledge the people who actually make these things happen, in particular Meredith Brown and the team in the Dean's office, so thank you. And now, Onye Arah.
Hi. So let's figure this out first, how this works. All right, okay. Thanks for having me. I've very much enjoyed meeting with a bunch of folks from around here. You have fantastic students, I must say. It felt like I was, preaching to the choir, and when I started off this afternoon talking to them, I learned so much. At some point, I just shut up and listened to them. And I hope we'll have a conversation today about some of the things I've already started discussing with some of these students. And Dean Gallier, thank you so much for having me. I appreciate the invitation. So we organized this talk around 5 things, basically tell you how I see socioeconomic context. Things I'm thinking about and trying to implement. The context. What do I mean? There have been critical gains, like the Dean just mentioned, critical gains made in understanding the socioeconomic context of health and disease. It is taken by most people. Very few people would actually argue to your face that there is no socioeconomic cause of ill health or disease. Some people would argue they're not quite sure it's actually causal, but they think that these things go hand in hand. When you hang around stuff and bad things happen, they begin to suspect you are responsible. So that's what it is with this. This context is a very broad idea that is what you could refer to as the global social exposome. That is the collection of the things that happen to us, exposures that we're exposed to that are socially and economically patterned. The idea is, and what we've noticed, is that these things are pervasive and cumulative and long-lasting, and they're typically seen as leading to what we call the SES, the socioeconomic status of a lot of people. It is multiple in nature, that is multi-component, it has multi-level in the sense it exists close to home, in our neighborhoods, our place of work, in our states, cities, in our countries, and across the globe. What is interesting that is happening, like Dean pointed out, is that there's a rise in non-communicable diseases, and there's a rise in chronic diseases. And chronic diseases you must actually understand as referring to both non-communicable and communicable diseases that we've now learned how to live with. That if you keep people, in fact, look at it this way, one of the successes of public health has been to keep people alive long enough for them to develop a lot of these diseases. So we have to deal with them. There are illnesses that there were cancers that were not seen in parts of Africa decades ago, but they are there now because we've kept people alive long enough for them to develop these cancers in their 80s. Now we're trying around to fight the fruit of our success. That's what we're trying to do here. What is interesting is that no one is showing up with just one disease anymore. As we get older, multiple things happen. And what is interesting is that when these things happen, who gets to have what you might have comorbidity or multimorbidity has to do with who they are, where they live, where they work, the neighborhoods where they find themselves in, the working conditions they get, the resources that the society would allow them to have or not have. And another interesting observation is that these non-communicable diseases are arising in places where we have not completely rooted out the infectious diseases. So we have a double whammy for them. They are suffering from things of the past that are decreasing, but they're still there, and then new things are coming in. And we have not had that sort of thing in the West for a very long time, in some cases decades. So here, in how I see the socioeconomic context is that of the shared. The word shared is quite important here. It's the shared social and economic conditions or systems or circumstances in which we are born, we develop, we work, we play, we thrive as individuals and members of a society or population. These would include the collective resources and power, structures, relationships, and institutions that are beyond us as people, beyond our individual control, largely. This is not to say that these are things that just happen to us. We create those circumstances. We create these conditions. I will put it to you that the idea of having an individual SES is actually not possible. The idea that you have an individual SES is not truly correct, is it? Because you exist as part of a society. And that you have that status means that you're part of a collective. And that status you have is usually with regards to how that society has decided to apportion power, relationships, resources. You're not poor unless they are rich. There's a concept of being rich. You can't talk about being poor unless there's a concept of being rich. You can't talk about your poverty getting in the way if most of the things you need in life are free. So it's important to understand that when we talk about SES, we're basically talking about something that is global in nature. And global I use in two senses. One, to talk about something that's beyond the individual person and your control, and to talk about the collective, the idea that these are shared things across borders. And so you've seen this framework that is practically everywhere now, and many people have seen it. We pay lip service to it. We also use it. The idea is, as individuals, we are within a web of things that shape who we are. From the very point, even before we were born, some things have been determined for us, whether you like it or not. You didn't get to choose where you were born. You didn't get to choose the country. You didn't get to choose your parents. You didn't get to choose their wealth for them. These things were kind of predetermined before we even arrived. So these things tend to shape who we are. And there are many levels where you get to go to school, what food you're able to eat, where you shop. All these things come together. This is a more involved one from New Zealand, where they've tried to work it out that, you can also see it in a very big global ecosystem. And this is very important when you start thinking about climate change, global violence, trade, all these conflicts. When you start thinking about these things, you realize we're on the same planet. It's not as if you get to take a spaceship out of here when things get really tough. We're on this together, and things that happen in one area affect others. Now, what is interesting here is that these things are not crossing borders in the sense that we're exporting these changing environments, the consequences of air pollution, trade, how it changes who has what resources and who is able to do work in a particular way. These things, when we make a choice here, sometimes it means something for someone else in another country. And this is something that is important, something we should bear in mind. This has become important even for local agencies and for the US, that even this framework from the Kaiser Foundation talks about how you can't actually talk about health outcomes unless you put all these things together. Issues about economic stability, neighborhood and physical health, education. And when you look at all these things, and many times there are things we like to say, what do you call it? We like to think individual characteristics, things that, oh, your health insurance, the debt you have, whether you're able to pay for your doctor's bills. But when you think about it, you will find that these things are largely socially patterned. They are molded by where you find yourself. The idea that here in the US we tie health insurance to employment is very important. Right? It's quite consequential, it has impact, it determines who is able to have access to healthcare, what quality of healthcare they get, and even when you can afford it, even when you can afford to have health insurance and you get into the health system to see a doctor, who you are and where you're coming from can also affect the type of healthcare you get, whether you like it or not. The doctor isn't blind. The doctor will treat you sometimes without thinking about it differently. Even though you have exact same health insurance, the same health system as the next person, you might not get the same care just because of how the provider perceives where you're coming from. So the society is really patterned in a way that it sometimes will feel like you can't escape it. Now, this idea of thinking that we're really tied to our environments led me to fresh out of grad school then, start thinking about what do we actually mean by individual and population health. I don't know how many of you wake up in the morning or go to school and start thinking, okay, how great, we're at the School of Public Health, we're doing all these things, what do we mean by health, what is individual health, what is population health, how do we even think about it? I don't know, how many of you have had time to think about these things? No? Now, I can see some people have had some time to think about it. I would encourage you to actually think about it, and you will realize it's not that easy. It's not that easy, and it's difficult for you to separate the context in which we are able to stay healthy, the context in which we're able to recover from anything that happens for us, from that what we actually achieve as individuals. It's quite critical that we realize that even the definition of health is very dependent on the environment, is dependent on the context that is driving it. Now, public health is supposed to be come up with actions, research, interventions to make our lives easier, to improve population health, the health of the public. And it turns out if you really wanted to look at how well public health is doing, you can't escape thinking about the contextual issues as well, the social conditions, the global circumstances that drive this thing. So then you have to come up with a framework that allows you to do so. Unfortunately, sometimes when you talk about these things, you go to a different audience. And this is a sort of thing that takes me to a philosophy conference, which can be very enjoyable. You spend 90 minutes with hardcore philosophers talking about these things. And I wouldn't advise you to read this. It will give you a headache. It gives me a headache when I read it. But that's the sort of thing you do with these philosophers. But because I thought about this a lot, when the OECD, the Organization for Economic Cooperation and Development, which is the a group of about the 33 richest countries around the world that collaborate on economic issues and development issues, they were trying to come up with a framework for how they measure health and monitor outputs of healthcare systems. They tried many times and they didn't succeed, and at some point they got this. Yours truly as a grad student, I was just finishing then, and so would you want to give a crack at it? We hear you like conceptual things. And I gave a crack at it and ended up, you can tell why I ended up being a professor and not an artist is that I can't draw. So that's not a pretty diagram, but it was convincing enough to the secretaries of health from those countries that they adopted this framework for studying the healthcare system and realized that I had to go beyond just the healthcare system and think about a system of health, which was something they hadn't thought of. They weren't thinking of doing it that broadly, but they bought into this. And that speaks to the idea that people, especially secretaries of health, can see the value of thinking about the environment in which we produce health, an environment in which we safeguard health, an environment in which we maintain health and cure disease. Now, so these are some of the greatest public health achievements in the U.S. in the last century. Look at this list. Can you think of any one of them that had something to do with largely individual choices and individual actions? They're largely things that involve large-scale shared intervention, going beyond our individual control in order to improve our health as individuals, but as a collective as well. So this is really interesting, that what you will consider some of the greatest achievements we had in history for public health all had to do with shared interventions, shared changes in our environment. However, you must ask yourself, have these achievements been equally distributed across the population? If not, why not? Did anyone miss out? Are there any specific groups who were likely not to get the same things? And these are things we should naturally ask ourselves. So if we're doing things in a shared way, why don't we all get the same thing? When you share a piece of pie or pizza, you don't like to be the person who didn't get enough of the pizza. It is interesting when you begin to look at things this way and you wonder, are the poor getting a fair share? Why not? Sexual minorities being left out in a different way? People who live in inner cities not gaining from these interventions? I mean, it is appalling when you think about it in the 21st century that you have to read news articles and talking about poor water supply in our inner cities in the U.S., colored water coming out of people's taps. I mean, these are the sorts of things that when you say it in Western or Northern Europe, they shake their heads in disbelief. How is that even possible in the 21st century? Guess who lives in these areas? These places where they get brown tap water or, poison in their water. Some of these people that are listed here. It rarely is the case that they have brown. Have you read about an article about brown water coming out at Bel Air or Beverly Hills? I haven't. So there is a social pattern to what is happening, whether you believe it's causal or not. The chronic diseases are changing, like I mentioned, in the world. They're changing in unequal ways, affecting different people. What is disturbing is that they seem to be changing in equitable ways and in ways that seem to suggest there's an unfairness to it. There is an exclusion going on, that there is perhaps discrimination going on that might be affecting who gets to bear the brunt of the new burden. What does it look like? Disability adjusted life years. Back in 1990, globally, you can see in the top 5 the kinds of things that were killing people or the kinds of things that were leading to a lot of disability. So you will see the communicable diseases and diseases that affect mothers and children and nutritional deficiencies were in the top. Now, fast forward to 2017, you see what's happening. We are getting a lot of non-communicable diseases coming up, shooting up. See all those lines going up this way? They sort of pointing to what you might call a shift in ranking that is going on. But this is the global picture. So you're seeing a rise of non-communicable diseases and a decrease in the communicable diseases. But this is not equal. This is not the same all over the world. So if you look at high-income countries like the US and Western Europe, you will find that it was in 1990, we had mostly non-communicable diseases on top, and we still do. But there are some things changing as well. Where one of the notable things being the switch in place between cardiovascular diseases and cancers. And cancers have now come up quite a bit, so much so that 1 in 3 people are projected to get cancers in these countries. The other thing that is also come up is diabetes. Diabetes is on the rise, and this is an important thing, and we think it has something to do with the way things are changing and risk factors, and these risk factors are socially patterned. Now, look at upper middle income countries. We're talking about countries that have soon almost at a precipice of breaking into the income countries that you will find in the West. And what you will find is that they used to have in the top 10 communicable diseases. They've largely conquered these and replaced them with a lot of non-communicable diseases. They're living with a lot of chronicity, and it comes with development. It comes with wealth. These are things that are being driven by economic systems, in a sense. Now, to see how it's being driven by economic systems, the countries that are next on the rank, we're talking about low, middle-income countries like Ivory Coast, Nigeria, you name it, and you will find that back then, in the 1990s, you would find mostly communicable diseases, but now there's a rise in non-communicable diseases. While they haven't quite lost out or put behind them the infectious diseases, new things that they will have to deal with. And these health systems, these societies, are designed to actually handle infectious diseases. Think about it for a second. Health systems funded largely with money from the West, designed to respond to communicable diseases, and now being faced by non-communicable diseases, and they're nowhere near being ready. Low-income countries, dominated, banned by infectious diseases, still so, but non-communicable diseases are coming up. Cardiovascular diseases are coming up. Now, look at the US. The US looks like every other high-income country as you would expect. It was mostly this, non-communicable diseases, and it remains so. But this does not tell you what's happening inside states. Inside states, say California, you will find that it looks much like the US, what is happening, but see the things that are beginning to change. See the rise in substance use, diabetes, a lot of these things are on the rise. If you look at yours truly, you would see that things are also changing. Not exactly the same thing as the entire US, but it has its own picture. And this picture is not exactly what you will see in California. See that the jump in substance use. I wonder, is anyone doing any work here in this state to understand what's going on with the substance use thing? Is it a crisis? All right, okay. The data seems to suggest that there's a big thing going on there. District of Columbia. You would almost think that this was not a high-income country when you look at a picture of what it looked like back in 1990. Think about it for a second. That back in 1990, the burden of disease, the picture there in DC was more like what you will find in a lower middle-income country. Does that worry you? And that if you were to dig in, you will find that it had something to do, there was a socioeconomic pattern to it, a dimension to it. The kinds of people who were suffering from these illnesses or who were bearing the brunt of this were quite different from the rest of the population. Now, a bunch of studies, and I'll try not to bore you with this, and I'm now trying to link quantitatively these the SES, global SES, to these chronic diseases. This is the commonest one, a graph everybody gets in school, I think. So you walk through School of Public Health anywhere, they give you one of these graphs and say, oh, look at how unequal the world is. The rich are doing very healthy, you know, the health and wealth graph. And you know this, and you see all the rich countries over there. But of course, there's more to it. What you would notice is that the socioeconomic differentials or differences you'll find in health exist in practically every nation in the world. Varying degrees. Some are doing better than others. So if you look at, for example, inequalities in life expectancy, looking at about 8 risk factors, you're going to find that some countries, especially in Europe, are doing better. I think I have a graph on that. So this is Denmark, Finland, Norway, Sweden. That there are big differences in educational differences in life expectancies in both men and women. More so in the men than in the women. But it's there all the same. And these are countries, I can tell you, someone who spends a lot of time in these other places, it's hard to believe that they have any problems. The place is gorgeous, everything works, you hardly see homeless people on the streets, you hardly see drug addicts on the streets, you hardly see people suffering, everybody has access to clean water, access to public transport, and yet your socioeconomic background in the socioeconomic background in those countries can predict who lives longer and who doesn't. In fact, in a study that we published in PLOS Medicine recently, we even found this for the children that are born to the mothers. We found that the children born to women who were of lower level education compared to the high level education were dying at a higher rate than you would expect from a very rich country like Denmark. And this just repeats right through these rich countries. Similar things can be found in poor countries. Look at this, reducing inequalities. One of the good pieces of news that come out of Europe is that they found a way to reduce absolute inequalities in cardiovascular diseases. But what's happened is that not everyone gained equally. Some people gained more than others. Who tended to gain more? The people at the upper rung of the society. They got most of the gains from the reduction, such that you will end up having not close the gap between the top and the bottom. Because the bottom didn't gain as much as the top, you still have relative inequalities that persist. Look at those graphs. You wouldn't expect to find this in Europe. Some people are often surprised when you show them this, that Europe does have problems. If Europe has problems, you don't want to know what's happening in Africa. We've looked at some of these things around the world in low and middle income countries, and we found largely, yes, that you can find educational disparities in diabetes and the relationship between body mass index and diabetes. So, and it can be quite pronounced in the low-income countries. We're talking about some of the poorest countries in the world. So they are not immune. I just showed you the other side of it, where Europe, very rich countries, they have inequalities. Very poor countries, they have inequalities. So, and we've looked at it in level of development of, in countries, trying to understand through which pathways this might occur. And these are some of interesting things we've been looking at to understand whether investments in the society collectively do make a difference, and it turns out they do. And this was one where we looked at corruption, especially focusing on African nations, and we found out that corruption is a bad thing. It's really dangerous to people born in Africa who have to live in Africa. So when conglomerates or corporations do business there, and they do business by supporting the corrupt systems, they actually supporting the loss of lives. This was another study that looked at gender inequality. Wherever you look, you find issues that the social condition is responsible for a lot of ill health. In this one, we also looked at various regions of the world and how the socioeconomic factors play a role. We even took a political view to it, welfare systems, welfare regimes, in the sense of how much of the safety nets, how much safety net they have for protecting them, for saving members of the citizens of those nations. And we find that there are important things to be said about having safety nets. Amenable mortality, the same thing. Now I'm bringing it home a little bit, and the study on the left is about Las Vegas hotel room cleaners, where we find out not having a lot of control over the work you do can be very, very detrimental to some biomarkers and to health. And this is not surprising, because we talked about how the work condition, where we work, where we live, all those things affecting us. And there's very little control over it. You look at shift work, whether you'll be assigned to shift work, how much you spend doing that. In Finland, we find that it's bad for heart disease. In all of this is one I just put in there to just remind you that when things go wrong, when people become sick, one of the things that happen, you would hope, is that they're able to get care. If you have a functional health system, if you have insurance. Now, it doesn't help you if you have few doctors, if you don't have enough doctors. And what's happened is that I showed you that high-income countries have their own inequalities, but high-income countries have been doing something that you might find disturbing, or not disturbing. I've been told before by a former president of Institute of Medicine that maybe it's not that bad of a deal if it's an economic system where the doctors from these other countries that I told you that have that double burden of communicable and communicable diseases coexisting, that they're losing their doctors. They're losing their doctors to the wealthy West. And it is disturbing that there's a pattern to it. And then when you link at it, I looked at it and tried to link it then to the Millennium Development Goals back then. And it turns out that, these losses were happening from places that could not afford to lose them if they were going to meet their development goals for keeping mothers and children alive. Those that were most vulnerable were the ones losing their doctors to the West. You might find that uncomfortable. The same thing happens. It's not just about not having doctors to see those who need help, the most vulnerable, is that when you get into the health system to see who you are and your socioeconomic condition also plays a role in how you are treated. I talked about this before, how you're respected, treated with dignity, given the appropriate care you need. You're able to see the doctor. This is something. Now we did an analysis. So we tend to do analysis in 3 ways. We combine multiple data sets on various levels about people, the individuals, their society, where they live, the environment in which they live, and we do this over time across multiple regions. It could be multiple countries or neighborhoods. That's one way. The other thing we do is that we take existing data sets or some of these data sets this way, and we try to simulate within those data sets using the best available knowledge about interventions of those social conditions that we can think of, and see how much we can change or move the needle in terms of those outcomes. The third thing we do is that we take this whole thing and we move it into a completely virtual world where we create virtual worlds to look at, with the best information from all these sources, to look at how we can intervene and which things play the biggest roles when it comes to affecting the outcomes. This is one we did in Pasadena. Could have figured that out, but it turned out that that was something. This is another one where we looked at the various interventions. This is one of those studies where I say we took everything and then we create a virtual world. In this one, we created a virtual Los Angeles, and we put in the best available knowledge and data. And we turned out that interventions that combine intervening on the individual, helping and supporting them, but intervening in the environment, in their circumstances, where the best things you could do to actually move the needle in terms of reducing obesity and subsequently type 2 diabetes. So let's skip that. This one, well, we can talk about it if you want to, if we have time to discuss that. The thing is that socioeconomic position is such that it affects how it affects our health, but it also affects how we politically engage with the processes that we're supposed to alter those conditions. And this was an interesting thing. I spent some time doing it, but I don't do it anymore. It got too political. My point is this, I want to put across, is that socioeconomic context or global SES can be seen as one of these things. We can see it as the cause of our ill health. We can see it as, well, is the risk factor for other risk factors. It predisposes us to all these other things that could go wrong, whether we're stressed or not, or able to get physical activity. These are other things. If you think about the availability of parks in your neighborhood, your work schedule, all these other things, that they might be what they do. Or they are things that might modify the effects of these other risk factors. That is, that if you have stress and you live in a place that has no parks, that you're worse off in terms of, say, your cardiovascular health than someone who has the same stress but lives close to a park because they get to, do something about it with the park, maybe. Or then you can say, well, they don't do anything. We just use them as nuisance factors to remove what you might call mixing of effects or confounders, or they're just proxy variables for these. Whatever you do, it is important for us to think about what it is if we are going to act on it. Because it's a question about the type of society we want to have, the kinds of people we want to be, the part of the collective we want to be. When we say public health, to me, the public path is really important. you have to ask, what does that public mean? To me, it means the shared, the collective, that societal perspective, that we're into something together about our health. We need to understand how this collective, especially when seen from the lens of the SES, how these things get under the skin, and which of the components of them do interact. That is, various components of the socioeconomic status might act in ways that are unpredictable. You know, are you poor and you live in a poor neighborhood? Are you a person of color? Are you a sexual minority? Do you have other things going on in your life at the time that are beyond your control? Do these things come together to make it worse, or do they cancel out? These are things we need to know. We always need more data. We always need to understand some of these things. We need to get deeper over sufficiently long periods. These are things we don't have enough of at the moment. So ideas moving forward. This, I just listed them because, in a sense, the boilerplate, in a sense, we have to ask the right questions with the right study design. The design might not always be observational. That is, data already existing and we analyze them. It might be doing something different for once, or doing an experiment. It could be intervening. We don't do enough intervention studies to find out what works and what doesn't work. And all the way through, as we think it through, we should get down to a place where we have to conduct what I call quantitative bias analysis. That is, what else could be going on? What are the alternative explanations to the signals we're seeing? That's what that is. This is saying we have to be thorough, we have to document it, and we have to entertain that we might be wrong. So that's that. So I'll leave you with this thought, and that is, I think schools of public health need to reimagine their mission. Many of us are doing this well already. Some of us could do better. And that is, we have to begin to build labs. I call these virtual labs. Labs where we test out ideas. Labs where we show what works and what doesn't work. We don't do enough of this. We assume we publish these fancy papers and they just get out there and some benevolent decision maker will take it up and say, oh, that's lovely. Why don't I implement this and things will look good? When you read through those papers, hardly would I ever come up with an intervention from any of these papers where I'm thinking, okay, there's something I can change. We need to translate these things. We have tons and tons of data in schools of public health. They need to be brought together into a platform, a repository for conducting what-if analysis. We should start offering computational population health science as a result. If we have this framework, we should offer people training and exposure to using data and the best available science computing systems to conduct what I call population health science, and perhaps even offer degree programs in it. We should see investigating the effects of SES on health as something that's cross-cutting. It shouldn't be in a separate department. It should be across departments. You should examine whatever PET study you're doing after you're done to see, is there a social component to it? If you find it, don't be surprised, because a lot of people have predicted and found in their own studies. If you don't find it, that is remarkable. That is something you should report. So, thank you for listening. I hope we can have a discussion, conversation about this. And, okay.
So first of all, thank you. That was terrific. So can you? I'm in agreement with the sort of counterfactual, with the in silico world to look at disparities. But can you talk a little bit about the training that you would recommend that students take to be able to do the cutting edge of this work 10, 20 years from now?
So I think students should be exposed, obviously, to causal inference and causal modeling techniques. I think that's important. But I also think students should be trained more in measurement sciences, in sciences of how do we measure things. You know, there's a whole apparatus behind thinking about what something means and how you measure it. So they're training for how do you measure health? How do you measure disease? How do you measure poverty? How do you measure social conditions? Anything you can think of, that you need that. Then you also need training in computation. And I don't mean just statistics for statistics. I'm talking about the ability to use computers in ingenious ways to lift complex data. Data engineering, data science, whatever you want to call it, ways to deal with things. I don't know how many of you have had to do an analysis and you want to do bootstrapping, but you have 2 million data points spanning 10 years. Who's ever had that problem here? Have you ever tried to figure out how you can get your computer systems or your computer clusters to actually lift 2 million data points observed over 10 years to resample and calculate confidence intervals? It turns out we don't train our students on how to do this stuff, and they are walkarounds. There are some programs that we've done using standard computational tools, and it took us a whole week just to run the program. At some point, we were so frustrated because we needed to do so many iterations of this. We called a next door neighbor, a statistician who we knew loved programming, was training computer science, and said, "Can you help us? I know this is taking a week. If we continue doing this, we'll be retired by the time we're done." And he decided to write a whole clean program from scratch in C++ for us. And you know how long it took? How he cut it down? He cut it down to 30 minutes. 30 minutes from scratch. Because he was trained in ways to compute and data engineer in a way that we weren't trained. And I think students should be exposed to it. I love the last batch of students I've trained. I've forced them to go and take courses and training in computer science, in computation, in addition to advanced statistics. I think that's important.
I wanted to bring you back to the end of your talk, I think, where you were suggesting that if we had these sorts of data, and we do have lots of findings already on this context that you discussed, that we could somehow make an impact. And how, can you help us think more about how to make an impact? It seems like such a huge problem. If a study says that a particular socioeconomic model is bad for health in a country, well, then you have to change the entire model in that country. Or if, how do we fix the disparities in economics or racism? Or these are we work on these problems, but they seem so big. Are there ways that are as big as the data that you see that we can begin to use to make changes in health globally?
Thanks. That's a great question. Some of the reactions you get to that I've heard will be like, it's so complex, it's so intractable that let's just throw up our hands and go home anyway. But there is something else we don't do enough of, and that comes back to what the dean was asking about. What else we want students to be exposed to in their training? We need to expose students to other areas of inquiry, to sociology, to all these other places where they can learn some theories and where they can learn about experiments. We don't do enough of that. So why these studies give us ideas about, say, hey, educational inequalities exist here, there are racial inequalities that exist here. The idea of what we can do or the mechanisms involved require that we have some other knowledge beyond our standard population health training. Now, if we get those pieces of information and say, well, it's not about your skin color, it's not about your education anymore, it's about the content of what you have, it's about how other people treat you, then these models can begin to use these pieces of information and say, okay, so what if we were able to find things that work in changing how people treat others. That's why I said it's hard to think of individual SES, because a SES is basically a label that says signals to society, which they can see how they should box you in, how they should treat you. Racism is one such thing. Someone decides to treat you differently and open doors for you or not open doors for you. If we can find out ways where we can train or change mindsets, it becomes not about changing your skin color or your label, but where people are able to allow you to be in a different box, That will matter. And for that, we need information from outside the classical models. But it's not impossible for societies to do changes. For societies to say, you know what, maybe people who have only high school diploma are not gaining from the interventions to improve cardiovascular health in Sweden or Denmark or something as much as we had predicted, because maybe we need to change their training. We need to give them more resources in a way we hadn't done before. It doesn't mean sending them back to school to retrain completely. It could also mean something else where we're pumping money into giving them whatever those resources we thought would be useful, or preparing them for what you call the 21st century knowledge economy, the service economy. And that's a problem. It's not just a problem in the US. What you see even in Northern Europe is that the people we call of low educational attainment are dying or suffering from what you call conditions of despair. They feel left behind. They feel they don't fit into the new economy, the new globalized world. What the politicians hadn't realized was that they need to be brought into the new economy. They need to be retrained. They need, subsidies or scholarships or fellowships to get into the new economy and be part of it and feel a sense of belonging again, and that despair would, hopefully evaporate to some extent. And that's something that is even in very wealthy countries that are relatively wealthier than the US. And there are actions that can be taken, and so, politicians need to pay attention.
This may be an unrefined question because I just keep thinking about it and it could be continually replaying in my head. But I'm thinking about the nature of the political environment that it is right now and how health communication plays a part in that. And there are a lot of, well-to-do professionals and professors and specialists in public health and medicine and things like that that say a lot of concerns regarding paradigms of health, such as gun violence and things like that, should now take an approach to looking at those problems from a public health point of view. And so I agree that we should move towards maybe looking at models that will allow us to see in a computational level what something might look like later on. But I'm also worried that if right now the environment is that we have a distrust of science and that we're struggling with health communication in general. And that even though we can talk about socioeconomic status and based on people's experiences, we can intrinsically say, oh yeah, that makes sense, I get that. But if we continue to build data and we lack the health communication bridge between those things, what do you think, how do you think we could solve something like that?
Thank you. If you figure out the answer to it, let me know. Just kidding. Health communication. So the way I look at it is, yes, health communication will be helpful when it does work, when you can reason with people, when you can present things to people. But if you say there's a huge distrust of the system of science, it usually goes with a distrust of society. There's a breakdown of the fabric of that society. We don't want to call it what it is, but that's what's happening in real time. It's breaking down, and I'm not really enthusiastic or really hopeful that mere reasoning about true communication is going to help, because maybe that's just symptomatic of a broader problem that is going on, and that is we're becoming ideologues, and our ideologies are beginning to separate at the seams, and we're deciding in the process, without actually thinking about it, that we want a different society. And every society has results that it deserves. The conversations you have, the ideas you have, the choices you make, you would have to live with. So if we've gotten to the point where we no longer want to pay attention to any of these things, perhaps we've gotten to a point where we want a different society. We just are not articulating it, or we're not listening. And that, I feel you need to solve first. I don't have an answer for how you solve it. The one thing I can say is that public health is about the sort of societies we want to build, who we want to be. And if we can't agree on that, we can talk about any social conditions we want, share the exposures we want for as long as we want, and not move the needle if people don't want to be together, if people don't want to pool their risks together, pool their resources together, share with one another, I don't have an easy answer.
Please join me in saying thank you.
Thank you.